All right, let's move on to our next speaker then. I'm really pleased to introduce Dr. Sandra Cortina. Dr. Cortina is going to talk to us about Ozempic uses and safety in reproductive age women. Dr. Cortina is an internal medicine specialist and a diplomat of the American Board of Obesity Medicine, and she practices obesity medicine in New Westminster virtually and also to patients across British Columbia. Dr. Cortina has a special interest in identifying the root causes of underlying weight gain and co-managing weight gain drivers to achieve best clinical health outcomes. She currently holds active memberships with the Eating Disorders of Canada and the Canadian ADHD Resource Alliance. And on a day-to-day basis, her passion lies in helping patients unlearn diet culture myths and replacing it with evidence-based weight loss information. She's an advocate for accurate scientific communication about weight loss, obesity management, and works to debunk diet culture and trends on social media. And I know we have been seeing Ozempic as a massive trend and getting tons of questions from patients and patients taking it. So I think this is a topic of interest to so many people. We're really pleased to have you, Dr. Cortina. I'll get you to go ahead and share your screen.
Amazing. Thank you. Thank you so much for having me. Can you guys see the screen okay on your end?
Yeah.
Wonderful. Yeah, thanks again for having me. My name is Sandra Cortina. I am an internist in the community here in New Westminster, and I want to talk to you guys about Ozempic because there is a lot of talk going on out there, and I'm sure you guys are getting bombarded with questions about Ozempic. So,
Dr. Cortina, we had your screen and then we lost the slides. Do you want to try resharing?
Sure, let's do that.
Okay, we see it perfectly now.
Can you? Oh, okay.
Maybe try advancing and let's just make sure it works. Okay, perfect. That's perfect.
Good. Okay, perfect. All right. So yeah, so why talk about Ozempic? Well, one of the big reasons is that there is a lot more people using Ozempic. There's a lot more women who are using Ozempic to lose weight. And as many of you guys know, for some fertility procedures, well, it's not exactly the fertility procedure, more the anesthesia requirements, but some fertility procedures may require weight loss beforehand. And so it's not uncommon that women are trying to get the weight down before undergoing these procedures. And, the other reason why is because, patients want information. They want information from their doctor as well. They are getting a lot of information online from the Facebook groups and, well, let's say TikTok, but they ultimately do want to get confirmation, validated information from all of you guys. And so what I hope to do today is to go over that information so you can relay it and have a good, solid conversation with your patients about it. So in today's discussion, what I want to talk about is I want to talk about what Ozempic is. I want to go over the current uses of Ozempic, and then we're going to go into the safety of it in reproductive women. We'll go over what to do pre-conception, how to manage Ozempic, and then of course there's this overshadowing Ozempic shortage, and so I'm going to give a little bit of an update with that as well, and we'll leave some time for questions at the end.
Dr. Cortina, could you scroll left on your screen just a little bit? The left side of your slides are slightly cut off. It's like we're seeing, there we go. Perfect. Thank you.
Is that better? Okay. Thank you. Sorry. All right. These are my disclosures with Novo Nordisk and Bausch Health. All right. Let's go over Ozempic. What is Ozempic? So Ozempic is essentially semaglutide, and semaglutide is, as occurs, what you guys know, is a GLP-1 agonist therapy, a glucagon-like peptide-1 agonist therapy. It's an incretin hormone, postprandial hormone, and it has a lot of functions in our body. Most notably, it helps control insulin release after we eat. It helps control appetite when we eat. Now, semaglutide can be packaged in a variety of different ways. We can put semaglutide in a pen and write Ozempic on it, and then now that's indicated for type 2 diabetes. Or we can, package semaglutide in a different pen, write Wegovy on it, and now that is used for obesity treatment. It's approved by Health Canada for both type 2 diabetes and obesity. Now, when it comes to the Ozempic pens, you'll come across maybe 3 pens on the internet, but really in Canada, we only have the red sticker pen and the green sticker pen. That yellow sticker pen is the 8 milligram pen, which is only available in the United States. And so these are the doses that we'll take patients to about 0.5, 2 milligrams a week, and we use that to treat type 2 diabetes. Now, when it comes, if I'm going to move over to the Wegovy side of semaglutide, there's a dose escalation, but the doses we use for obesity are 1.7 milligrams to 2.4 milligrams. That's the maintenance dose. It was approved by Health Canada in 2021. We still do not have Wegovy physically in Canada. And the drug reps have even told us they don't even know when Ozempic is going to physically be available in Canada. And so that is the main difference in kind of the status of semaglutide and its states in Canada. Now, considering we don't have Wegovy, what's happening is that a lot of prescribers are just using Ozempic. We are prescribing it off-label, right? But we're getting semaglutide to treat patients with obesity using the Ozempic pens. We are using it off-label, and there is an increasing number of off-label uses of Ozempic. Especially this year, you guys have probably noticed there has been a few really large trials that have been published that have shown its benefit in preventing major cardiovascular events, right? That was our SELECT trial that demonstrated people using this with a history of heart disease reduces future heart attacks and strokes by 20%. So that's going to be something you guys will probably see as a newer indication. As well, we had a STEP-HFpEF trial, which looked at how semaglutide helps heart failure symptoms in patients with heart failure with preserved ejection fraction. Significant findings. It's actually the most effective treatment for treating HFpEF symptoms, even more than SGLT2 inhibitors. There has been some suggestions that it helps with PCOS treatment and subfertility due to type 2 diabetes. But the big off-label use, of course, this elephant in the room, is for obesity, is for weight loss. And these are the results of the SELECT trial. These are the results of semaglutide 2.4 milligrams a week. What is significant here is that on the average at 68 weeks, the estimated percent body weight loss is 14.9%. That is the intention to treat results. The results are actually, when you look at actually the results from women, they're actually a bit higher in women because women respond, for various reasons we think with what's going on, but women do respond better to this medication. What is important to keep in mind is that if you look over to the very far right, over 1/3 of patients will achieve 20% body weight loss. And that's what makes this significant, because before semaglutide, I wasn't able to quote that number unless we were talking about bariatric surgery. And that's why this has become a very popular medication. Now, when we're looking at specifically women of reproductive age, I want to keep in mind that, the SELECT trial didn't actually go and take a look at how many women of reproductive age were in the study. But we do know that at least in the per protocol analysis, 78.4% of participants were women, and the mean age was 49. So you can kind of take that with a grain of salt, trying to interpret these results for women of reproductive age. What about the safety? Okay, is it safe? And what are we going to tell women who are trying to get pregnant? Well, it is, of course, it's limited right now, what we know with safety, and a lot of it is really extrapolated from animal studies. So we know that when we've looked at studies with pregnant rats, what's happened is that there is reduced growth, there's increase in skeletal and visceral malformations. When we looked at a group of monkeys, I'm not familiar with this species, but what they found is that there was more frequent early pregnancy loss. It was at greater doses of semaglutide than used in humans, but still. And so extrapolating from that, it is suggested that it can possibly cause harm, and therefore semaglutide is not recommended during pregnancy or in breastfeeding. Due to its long half-life, right? Because this is a once-a-week injectable, it is recommended that we counsel women that they should stop the medication 2 months before a planned pregnancy, right? So that's kind of where we are with the safety data. It's extrapolated from animal studies. It's not the best, but it's what we're working with. Okay, no, but has there been any WHOOP studies, any exposure studies? Has anyone gotten pregnant on the medication to see what happens? Well, right now, there's at least one case report that has documented a case of somebody who has gotten pregnant on semaglutide as a whoops situation. And so this was published this year, actually. And so there's one case report, we'll go over it. And it's a 31-year-old woman, G2T1, who was using semaglutide 1 milligram a week, and it's off label for PCOS. And this patient lost 27 kilograms and had a BMI of 29 at conception. The last injection was taken at about week 3, day 4. And due to its long half-life of semaglutide, they considered this a prolonged exposure, probably around 6 to 8 weeks extra exposure. Now, the result of this case is that, well, this patient delivered at gestational week 41 and 5 with macrosomia, and the labor was complicated by shoulder dystocia. And of note, there was no gestational diabetes in this case. There was weight regain during pregnancy with a total weight regain of 35 kilograms. And the authors noticed that it was probably about 1 kilogram a week. And together they concluded that, at least to a degree, the maternal weight gain and the fetal macrosomia was at least partially due to this rebound weight gain when we stop the medication. And we know that when we stop the medication, the weight does come back. It's not overnight, what I tell patients, but it happens gradually over time. Right. So so that is the main safety stuff that we have, that we have information about. Now, of course, there is this looming Ozempic shortage, and there is this also new kid on the block that I do think it's important to talk about. And this is, of course, Mounjaro or tirzepatide. So as many of you guys know, there's a large shortage in Ozempic, and the reason why is because we're not actually short of the medication itself. We are short of the injector pen, that plastic pen. That's what we're short of, and that's what's making this shortage happen. The shortage is expected to last until April. And so in the interim, there have been some substitutions that we have been doing, but the biggest news is that tirzepatide has now become available and was literally available yesterday to start prescribing. And this is also a GLP-1, but also a dual incretin. So it has 2 incretin hormones in it, not only GLP-1, but also GIP, which is glucose-dependent insulinotropic peptide. You can think of it as a GLP-1 booster. And the significance of using this medication is that we get greater weight loss outcomes due to the dual agonism, and also we get less side effects. This is the results of the weight loss trial using tirzepatide, the Surmont trial. And what it's demonstrating is the average estimated percent body weight loss is it's 20.9, but nearly 21% body weight loss. And that is very significant when you compare, remember, the Ozempic, the high-dose semaglutide trial, average weight loss, 14.9%. Now we're getting into 20% range. So expect that patients are probably going to be switching over from Ozempic to Mounjaro as this shortage kind of continues. So be familiar with this one on the block. What's important to keep in mind with this one when it comes to fertility is that we know that tirzepatide is significant in the gastroparesis side effects, right? This is the slowing of the gastric emptying, and it can interfere with the absorption of oral contraceptive medications. And so what's recommended for any of your patients who are on Mounjaro is that they use a barrier method during initiation and for 4 weeks after any dose escalation, or instead switch to a non-oral contraceptive method if they're going to start tirzepatide for weight management. All right, those are that, and so that was the updates there with the safety of Ozempic in reproductive age women, and I'm more than happy to take any of your questions.
Perfect. Thank you so much, Dr. Cortina. I know a lot of people probably have questions, lots of patients on Ozempic. We have one that says, can you speak to muscle wasting versus fat loss on Ozempic?
Mm-hmm. Yeah, absolutely. When it comes to Ozempic, it's somewhere between 15 to 40% of the weight loss is muscle loss with it. So it's not all just fat mass. And this is actually a similar phenomenon to what we see in patients with bariatrics who undergo bariatric surgery. There's always this degree of muscle loss with it. And so what I always tell my patients is just what I tell my bariatric patients as well. The best way to prevent this is to prioritize the protein when you're with your meals and to also stay active. But it's a real bonus if you can do some sort of resistance training to really just use your muscles and show the brain that you're still using your muscles. And so the loss of muscle is it's a real concern, and that's how we kind of get around it. But we don't have data to say that, like, to show how much that could prevent, though.
Okay. Another question here. What would you advise for patients who want to come off Ozempic? Anything to reduce the rebound weight gain, specifically if they're considering getting pregnant?
Yeah, so the degree of weight gain, the weight gain will come back, and we have the data to show that it does come back. And I always tell my patients, this doesn't happen overnight, it happens gradually, but it will come back even during pregnancy. There is weight rebound. There's nothing, beyond just, following the regular dietary recommendations during pregnancy. There's nothing we can really do because we're just shifting that hormone. We had the hormone on, now that extra hormone signaling is off. But once pregnancy is done, nursing is done, then we can always restart the medication. And that's really how we get around it.
And someone is asking, are these effects similar with Saxenda?
Yeah, absolutely. Yeah, absolutely. With Saxenda, it's recommended that the rebound effect is similar with Saxenda, but I will make note that for somebody who's on that medication, that's a once daily injectable, and it's of liraglutide. And so because it's a once daily injectable, the half-life isn't as long. And so you can stop that medication just 2 weeks before conception or pregnancy planning.
And they're wondering, is the muscle loss the same as well?
With the Saxenda?
I think it's referring to Saxenda. I think the question's about Saxenda.
Okay. The muscle loss depends on the amount of weight loss. And the amount of weight loss always depends on what dose sometimes of what medication you're on. So I always put Saxenda comparable to Ozempic at a dose of 1 milligram a week. Okay, so when you compare those two, the amount of muscle loss will be the same. You can kind of think of it that way. It doesn't make it any difference because it's once daily injectable.
Okay.
Answered the question.
And somebody's asking about evidence of semaglutide on egg quality when doing IVF. I am not aware of any good data on egg quality when doing IVF. Are you, Dr. Cortina?
Egg quality? No. Can you elaborate? What do you mean by egg quality? Or you mean like fertilization?
Yeah, I think it's an interesting question because what they probably mean are IVF outcomes. Egg quality is sort of a difficult term because defining egg quality is subjective. We look at eggs under a microscope, then we see how well they fertilize, we see how many of them become blastocyst embryos, we see how many of those embryos sometimes are genetically normal, we see which ones make babies. I'm not aware of any data, at least high quality data that connects IVF outcomes with Ozempic, but to be fair, there may be, and I did not do that lit search before answering this question. So how about I leave that question open and I'll do a little research and put anything in there that I see. But I don't know, Dr. Cortina, if you're aware, other than that case report you presented on pregnancy outcomes, if you're aware of any fertility treatment outcomes and Ozempic.
Yeah, so there is one study that looked into liraglutide, and it found that there was increased IVF rates with that study, and I can probably pull it up here too, because I can't remember the exact details of it. But there is it's a small study that showed improved IVF rates with liraglutide.
Perfect. That would be informative for me as well, and probably some of my colleagues on the call. So what we'll do is maybe pop that if there's a reference into the chat, you can add that. I have a question for you, which is about, this has been written about even in places like the New York Times, where they talk about the potential anti-addictive properties across the board of Ozempic, and people taking Ozempic and saying my compulsive shopping got better. So do people ask you about that? Do you have a comment on that?
Yeah, so with and I'll just share my screen here with the IVF paper while I'm talking about that.
Perfect. Thank you so much.
See that one?
Okay.
There you go. Okay. So the anti-addictive properties of semaglutide is pretty cool, because what we know is that we all are familiar with the reward pathway in our brain, right? That's the addictive part of our brain, the craving and the liking center of our brain. Well, did you guys know that that part of the brain also has GLP-1 receptors all lined up along it? And so you probably even notice, like, some patients will go on semaglutide and go, I don't have cravings, I feel great. And they'll also note, some will also experience that with alcohol, gambling, sugar. So things that are addictive, that they'll find that they're just less compulsive towards. It's not everyone. So I do have a lot of people who also have alcohol use disorder, and I put them on semaglutide and they don't notice a change on their alcohol, right? So, but for some people there is, and it just kind of varies, and it probably comes down to what we inherited for the number of GLP-1 receptors in that area of our brain is probably what it's going to come down to. Yeah.
Excellent. Okay. Are there any more questions? Because we do have a few minutes with Dr. Cortina. Otherwise, I know that our next speaker is ready to go. Thank you so much for this study, because I'm learning even more today.
Very welcome. Thanks for having me.
Perfect. Can I ask one more question? This might be relevant. If you're going to put a patient on Ozempic or a similar medication, are there any labs that you must do at baseline, or any labs that you need to follow during the course of medication?
Yeah, great question. There is actually not, but I do like to have baseline liver and renal panel, but having like renal dysfunction is not exactly a contraindication with the medication. But ones that I like to have for baseline though include a hemoglobin A1C, and I also include a CRP, and so those are the baseline lab tests. Those are consistent with the obesity guidelines, with the exception of CRP. So the CRP is just something I add, but because we know that obesity does cause this low-grade inflammation, and I like to see if it's there. Because if it's there, what I like to do is I like to repeat or do an interval lab test to see it improve with the weight loss. And so but there's no, nothing is absolutely necessary, but I do those ones.
And somebody's asking if Mounjaro will cost the same.
Mounjaro. No, Mounjaro is going to be Mounjaro. I've been told it's $90 a vial, so $90 a week. Okay.
Wow.
Yeah, and so and there's single-use vials as well. So Canada isn't getting the Mounjaro injectable pen, which, if you guys maybe notice, like from just American media, it comes in like injector pen, just like Ozempic, similar, but we're not getting that. We're actually getting single dose vials, and patients will need to get the vials and then also get syringes and alcohol swabs, and then do the injection at home themselves and do like the whole technique that way. So $90 a vial. there is a small discount that the manufacturer is offering on their website that patients can sign up. I don't know what the discount is. It looks like it depends on what the patients have for insurance. Like you have to put in your insurance details, and then I guess they sort out what the discount is going to be.
Okay.
So, yeah.
And then someone is asking, can a patient ever get off Ozempic? Because you talked about the rebound weight gain. So how do you avoid it? Or is this a lifelong medication?
I tell everyone lifelong. Well,
Wow.
I tell everyone lifelong, because we know we see the weight does come back to a degree. What we think, this is just a hypothesis, is that it's likely that 5% of the people who come off Ozempic will be able to maintain the weight loss, because that is the statistic we know of the percentage of people who can do weight loss with lifestyle measures alone and sustain it. So we know that 5% of the population can lose weight on their own with lifestyle strategies and keep it off lifelong.
Okay. And Dr. Hujapenner, I think your hand is up to ask a question. Can we unmute her, please?
Can you hear me?
Perfect.
Thank you. Sorry, I can't type a question, I guess, because I was a talker in it. Thanks, Dr. Cortina. I just was curious on your opinion of using semaglutide for improving fertility, or like I've seen patients refer to me BMI over 45 who want to do IUI or IVF, so to bring their weight down, or, you know, for our PCOS patients, we know it can help with ovulation to lose that weight, but then we know we have this like rebound weight gain. So I'm just curious, like, is it something you're still doing in your patients that you're trying to optimize for pregnancy? And then how do you counsel them coming off of it, other than, you know, trying to continue healthy lifestyle to try and avoid that macrosomia risk and that weight gain?
Yeah. So in my experience, it's usually been in cases with PCOS that where patients have been referred to me, especially prior to fertility treatments, because they don't have an anesthesiologist. So I counsel, such as, you can go back on it afterwards, and in the interim, you know, just reduce the processed food, because that's the best way to reduce processed carbohydrates. It's all about reducing the processed carbohydrates.
Do you feel it is still a reasonable treatment to optimize that, like BMI, for instance, prior to going through with IUI, even though they're going to be off for that 8 weeks and have that rebound weight gain?
Yes, I do. Because, you know, here's the thing with the case report too, is, was it the Ozempic, or would have that happened anyways? We don't know. I don't know. And I don't think we have enough data.
Thank you
But
so much.
I also have patients too, is like, they can't even get the fertility treatments until their BMI is less than 40.
Exactly, yeah.
And well, we know that lifestyle strategies on the average only leads to 5% weight loss. I should kind of signpost that too, because there is a very common misconception out there that people can lose whatever they want with diet and exercise and they'll be fine. But that's not what obesity is. Obesity is a disease where the brain, our subconscious brain, is stuck. It has put our set point weight inappropriately too high. And, you know, using diet and exercise isn't going to get that very far when our brain is stuck or set point. And so, yes, I do still think it is worth it to do the medication beforehand.
Thank you.
Okay, and we'll do, could Mounjaro be an option for patients who do not respond to Ozempic?
100%. Absolutely. That's pretty much what I've been doing all day today.
Okay.
Yeah, I just switch over.
And why is it some people do not lose any weight at all on Ozempic? What's the reason?
I love that question. Yeah. So obesity is a disease, and it's largely centered in the brain. And there are a lot of appetite pathways that are in our brain. And it's not just controlled by GLP-1, it's controlled by a lot of other receptors. And so it's not uncommon, and it just comes down to what we inherit. We all inherit a different appetite receptor profile in these different pathways. For some people, it's not GLP-1 that's the issue. And there's been a few times where, we go ahead and we're doing the semaglutide, we're pushing with the semaglutide, and we're not really getting anywhere. Stop the semaglutide. put on Contrave, now we're getting somewhere. And Contrave is the second medication that's approved for obesity by Health Canada, which, as you guys probably know, is a combination of just bupropion and naltrexone. So again, that's working in those appetite pathways. And so when we use that medication, for some people, it works better. And now the weight's coming down. So it's trial and error. But GLP-1 agonist therapies, I would say, they work for a lot of people, if not the majority of people, especially if you push the doses high enough.
Okay, and last question, can semaglutide be used intermittently to maintain weight reduction?
In theory, but I think I would anticipate that people are going to feel, in theory, sure. I guess I'm not sure how to answer that question. I would stay on it consistently, but if cost is an issue, I don't know if there was another side question to that one.
Okay. Okay, that was a very robust question period. Thank you so much for answering all those questions and for sharing your knowledge with us. That was really, really helpful.
Sure, just ask.
Oh, that's my Siri, sorry.
Oh, thank you, Siri, too. All right, thank you, Dr. Cortina. So